Good morning, everyone. Thank you for joining us in our international rounds. And it's my great pleasure to introduce a friend, it's Dr. Daniel Tobler, that is going to talk today about the Epoch, which is the acronym for the European Collaboration for a Prospective Outcome Research in Congenital Heart Disease. So thank you, Daniel, and thank you for joining us. And the floor is yours.
Yeah, thank you very much, Rafa. I want to take this opportunity to congratulate you as the new director. So you're an excellent clinician, interested researcher, and a nice guy. And I think that's very important because about this friendship, I want to talk now with the next 40 minutes. So hopefully I can start. I go down. Where is that? Okay. So I will talk about Epoch, the European collaboration for prospective outcome research in congenital heart disease. I don't know, yeah, now. And the image you see here, that's a mountain pass, and you see the view to the Mount Matterhorn on the valley. And why I show you this picture, I will tell you later. So, okay. So this is the agenda. I will tell you what is Epoch and why we did it and who is it. I will give you an overview about our first project, the arterial switch operation cohort. And finally, I give you also an update about our COVID-19 study. Well, outcome studies are urgently needed in ACHD, and you all are aware of some very, very important question in adult congenital heart disease. Now, since more than 20 years, we are in debate about when and how and if at all pulmonary in repair tetralogy of Fallot with pulmonary regurgitation. We have a lot of questions in Fontan operations about the liver. We know that tricuspid regurgitation is a bad thing in CCTJ, but we do not know when to replace. Even anticoagulation, which we do so often in CHD, we have no clear regime when to anticoagulate patients, for instance, after an ablation with intra-atrial recurrent tachycardia or Fontan. And also we have no idea about what we have to do with an aortic root dilatation in the setting of an arterial switch and so on. So what are the barriers in outcome studies? The barriers are, of course, small numbers, particularly in Switzerland. We only care about 7,500 ACHD patients all over Switzerland. And this is actually not so bad because we only have about 8 million of population. So 1 of thousands of Swiss people are under our active care. So we think we have not a problem of transition and the transition clinics are not that bad installed. It's more that these patients just is a minority. And one of the biggest issues is the short follow-up. And follow-up in outcome studies in congenital heart disease is about 2 to 3, maybe 4 years. But actually, we only have few outcomes, and we should wait for much longer time, I would say decades. Then patients with congenital heart disease vary widely, and they have a lot of different lesions, so it's very difficult to compare these patients. And also follow-up with, for instance, surveillance is very different in different centers, and that's very difficult to compare. An issue is time restriction. We all know that we don't have the time. Most of us, we are working 100% clinically, at least I do, and everything else we do in research, we have to do after the work. This is a problem for life-work balance and so on. So we need finances we don't have and so on. And finally, the individual barriers in the academic world. That's maybe not everywhere the same thing, but at least in Europe, I have the feeling that often it's a battle between centers, which shouldn't be. This is rivalry, sympathy, selfishness, all these issues we have to deal on daily academic business. So how to overcome these barriers? Of course, we should involve more centers, do multi-center studies, to increase the numbers of patients. And then we need a setup for longer follow-up in our research. Actually, we need decades until we really know the hard endpoints, for instance, mortality in patients with tetralogy of Fallot after pulmonary valve replacement, if it's good or not. And with that, also, we would have more outcomes. Then we need standards. We need standardized protocols for imaging, for follow-up, for surveillance, standardized standardized protocols, how to do the image and when to do the image. Finally, time restriction. What we do in Switzerland, we hire fellows and we hire so-called master students. These are students studying medicine, and these students, they have to do 400 hours of work for free. So we try to have these students, of course, for work like data entry and doing smaller studies. Finally, how to overcome the individual barriers in the academic world. That's very, very difficult, but I think the key for successful collaborative research is to create an ambience of friendship and trust. And as a fellow in Toronto, I had this experience quite extensively when we had our end-of-life team, and we were working together with Matthias Kreuzmann, and still now we have friendship. Maybe you could thank you. And still today we have a friendship and are in close contact. And based on the friendship idea, we were when we were in Barcelona with Markus Schwerzmann and Matthias Kreuzmann, so Swiss colleagues of mine. We were at dinner with some colleagues. Thank you. With some colleagues from Amsterdam, particularly with Bertha Boma, and then the idea of Epoch was born. So the idea was that we do a consortium of centers in which we have trust, because these are all our friends, and then we do long-term outcome studies. So I then invited several friends for a brainstorm meeting in Saas-Fee, Switzerland, which is about 4,000 meters above sea level, so they couldn't escape during the meeting. And you see all these people, first time so high, the Spanish group here with Pastora and with Laura, so Amsterdam was there with Berto, some Swiss guys, and also Magali from Paris. And of course, the most important part of this brainstorm meeting was not work, but everything which has to do with leisure time. This was a bonding event. We had some activities on winter sport. We had some typical Swiss dinner. We even had some alcohol. We were hiking and walking. We had sunny weather. And finally, we also were working at some hours. And at this time, we were deciding what we want to do and how we want to do it, how we want to set up, which group of patients we want to investigate. And of course, the advantage of Epoch is that we have a lot of patients under active care. So currently, we have 11 centers in Epoch in France, Austria, and the Netherlands, Switzerland, and Spain. And about 35,000 active patients are under care. And I have to tell you, this is not exclusively, and we still are very open that other centers will join us. For instance, we don't have anybody from Belgium, we don't have centers from Germany, Italy, and from the eastern part of Europe. So at this brainstorm meeting, we decided that the first project should be a cohort of adults with the arterial switch operation for transposition of the great arteries. And the reason for that was that it is a relatively new cohort in ACHD, and it's fast growing. It's a fast growing cohort because we know that in childhood, most, when not all children will not die. And this is very important because when we know that about 97% of children will survive, then we also can calculate how many patients we will care in future. Also, these patients, although they are very good, have important residual lesions we have to study on, and we don't know the impact of these residual lesions on outcomes. And finally, only few outcome studies are available. The arterial switch operation, that's the story of heart surgery. Because before heart-lung machine, patients normally died, and only a handful of patients would survive to adulthood. And then in the 50s, they tried some historical operations with more or less a success. And finally, Mostert and Senning could overcome these barriers. And we know that this patient with an atrial switch, they survived quite well into adulthood, but they are quite worrisome, and most of the problem beside the Fontan patients we have in this group of patients. This changed when Chattin's operation came into clinic. So when about in Switzerland, it was about in mid-80s when the arterial switch was first performed. And nowadays we know that we have a very good outcome, and at young age the outcome is better than the arterial switch. We have a few outcome studies all in 10 years ago about. We have Toronto group, we have from the UK, then from the US and the Spanish group. And there were just about some couple of hundred patients with a short follow-up, and 20-year survival was overall about 96–97%. In this short follow-up, we had just a handful of deaths, and so what also was important, that we had some residual lesions already in this short follow-up. So we could see interventions for pulmonary stenosis, particularly for branch stenosis. And the most evident problem was aortic root dilatation, which we see in quite a lot of patients associated with increasing aortic regurgitation, and in some patients we already had aortic valve replacement. But overall, function is excellent. Most of patients, when not all, have functional class 1, have normal ejection fraction, and the only difference between the study was in exercise capacity, which was lower in the Toronto group, most likely because these patients had more frequent an RVPA convict before the Leconte maneuver, and we know that this kind of pulmonary stenosis has an impact on exercise capacity. So is it all good with the arterial switches? As you know not, this is an image from a baby after the arterial switch operation in Zurich, and you can imagine that even if the outcome is good, it's a catastrophe for the parents. And we always have to be in mind that this operation is very stressful for everybody. But what I want to tell you now is that we should go to a paradigm shift in care. So in pediatric cardiology, it's often the term long-term outcome, because of course when they have a child born with a severe defect and this child is operated, they are looking for long-term outcome, like 10–20 years outcome. But when we know that 97% of patients will survive into adulthood, we need a lifelong management. So this is an overview from Dr. Villafañe in 2014, which I think is an excellent summary of how this lifelong management could be like and what are the challenges. So first, it's the absence of current consensus regarding appropriate interval and modality for surveillance imaging. So surveillance imaging now, I think we have 4 years later than the paper came out, we have some guides how we should do it in the AHA, ACC, ACHD guidelines. At least that's very practical. We can see when a patient has to be seen about 12 to 24 months when he's in physiological stage 1, or more when he's worse, of course. But imaging is not so easy, particularly when it comes to echo. And looking at this image, I want to remind you that I think the term anatomic repair in arterial switch, it's misleading. It's definitely not an anatomic repair. The only anatomic feature that you have is the left ventricle being a subaortic ventricle, but everything else is not anatomic, particularly not the pulmonary branches and the pulmonary artery, which is sometimes very difficult to image and often you only can see from a suprasternal view. The aortic valve is not an aortic valve, it's a pulmonary valve. The coronary artery are replaced and so on. Then we need MRI in these patients because all the residual lesions actually are difficult to image with echo, particularly the coronary arteries and the pulmonary branches, and also for the aorta we need a better imaging technique than the echo. Ischemia is a problem because we don't know if a patient has ischemia, we don't know how to handle it, we don't know if a patient has symptoms or not. So how do we do surveillance with, for ischemia? We did, when I was in Toronto, a study with Andrew Green and Rachel Wald, when we compared SPECT and MRI and could see that particularly SPECT imaging has a lot of false positive results leading to unnecessary coronary angiography. So we don't know what to do with this topic. Secondly, the lack of defined management strategy when subclinical anatomic or physiologic abnormalities are identified. What do I mean? One of the striking studies in children was by Pedra in 2005, which showed eccentric intima fibrosis in an intracoronary angiogram. And this looks like as in patients with heart transplantation rejection. So this study actually could never be reconfirmed, but still we are at some worry. Also, we know that the aortic root is growing during adulthood. This was a 2019 study from the Amsterdam group, which showed persistent neo-aortic growth during adulthood, whereas during childhood, it was a stable measurement. So we don't know what to do with this finding. Because when we go on, then what should we do with an aortic aneurysm in an arterial switch operation? Should we operate on with 5 centimeter, 5.5, 6, or not at all, or is it depending on aortic regurgitation? And I show you some data from a German hospital. They had operated on 12 patients with an arterial switch operation for an aortic dilatation, and you see half of them are children and half are adults. And when you look at the numbers when they operated, they were quite low. So 5 of 6 were under 50, and only some had aortic regurgitation. But what is striking, that all ended up with a benthic procedure. So not only it was the aortic root, it's also the aortic valve, which had to be replaced with a mechanical valve. And of course, this is after that you have a valve disease. First you had a vessel disease, but now you have a valve and vessel disease. And when it comes to surgery, you have to be in mind that the surgeon does not have the aorta in front, but the pulmonary artery, and often he has to transect the pulmonary artery and then to reimplant an interponent, just that you have a good look to the left ventricular outflow chart. The rarity of symptoms attributable to potential complications, that's particularly something with the coronary obstruction. When I was a fellow and doing this study about transposition, I had a lot to do with Bill Williams, who was telling me about the problem that these children, after the arterial switch, they have a sympathetic denervation of the coronary artery and often do not feel the pain, only have shortness of breath. So symptoms of angina are not reliable in patients after the arterial switch operation. And we know now from a recent study from Zurich, from Matthias Posner, that this is partially true. Even now, if these patients are adults, that the sympathetic denervation is not as it should be. And finally, and this is probably the most challenging because it lasts decades until we know what is actually the effect or the unknown effect of acquired coronary artery disease superimposed in manipulated coronary artery. And I have shown you this study from Pedra, where you have intima fibrosis, but of course you have other features of diseased vessels, like a reduced coronary blood flow reserve. Excuse me. Like a reduced coronary blood flow reserve, such as impaired myocardial blood flow under stress, and finally impaired coronary reactivity. So these are clearly diseased coronary vessels. So what happens? What happens if all the acquired diseases come on top of this, I say, congenital disease? So that's why we have to teach our patients with anticipatory care, and we have to practice them a low-risk lifestyle, such as healthy body weight, physically active, no smoking, alcohol in moderation, and healthy diet. Because with these 5 habits, we can actually prevent about 79 of myocardial infarction, and this is in a normal population. So maybe if we do this in a patient with arterial switch operation, endothelial dysfunction, we can prevent until the patient is older. So all these are the rationale why we have designed the comprehensive long-term follow-up of adults with arterial switch operation by Epoch. And you see all these doctors who are joining us. So we have Magali Ladouceur from Paris, Pastora Gallego from Sevilla, Laura Dos from Barcelona, Joaquin Rueda Soriana de Valencia, Berto Boma from Amsterdam, Harald Gabriel from Vienna, Markus Schwerzmann from Bern, Judith Bichardi from Lausanne and Geneva, and Matthias Greitmann from Zurich. So what we did is, first, we have quite a low eligibility criteria. You only have to have an arterial switch operation for transposition of the great arteries or for a double outlet right ventricle, and being older 16. And when you are older 16, you are included into the study during your next clinical consultation. And then we did extensive baseline examination. And all these examinations are actually based on the current guidelines. So we have medical history, of course, clinical examination, quality of life, ECG, and an echo. And then we perform in every patient an MRI, a coronary CT, and a cardiopulmonary exercise test. And this is justified clinically, the cardiac magnetic resonance imaging for the pulmonary arteries and the coronary CT for the coronary arteries. At least in the guidelines, it says do it once when the patient is an adult. And after 5 years, we repeat the CMR and the cardiopulmonary exercise test. We do not repeat the CT, because when we did the CT, we did it to assess the anatomy, and probably this anatomy will not change. We also standardized these procedures. So every procedures we do, we did an SOP saying why we should do it and when we should do it. And also we did a data acquisition. And for that, we went to our radiologist and asked them if it's clinically possible, because we do not have the finances to pay this examination, and we do it on clinical basis. So the radiologist has to be informed that this is a patient with an arterial switch operation, and he has to do as we want to do it. And that's why all these protocols were made in close contact with the radiologist of each center. The only core center that we have is the core center for coronary CT, because we will have a very close look at the anatomic feature of the coronary arteries in patients with arterial switch operation. We will measure the minimum and maximal ostial coronary artery diameter. I have to say this core lab will be in Paris. Then we are interested in the proximal vessel morphology. Does the patient have a normal vessel, or is it oval or slit-like? We want to know the length of narrowing. We want to know other features, such like the course of the coronary artery, and also take-off angle and the take-off level, because there are some data from patients with coronary anomalies showing that the take-off angle and the take-off level, they have an impact on shear stress, and will differ shear stress and have an impact on arterial sclerosis in these vessels. And finally, we also want to know the type and branching of the coronary osteas. So what we actually do is a very comprehensive anatomical assessment. We have predefined outcomes. We want to know all-cause mortality, cardiac-related mortality, about re-interventions, neo-aortic dissection, myocardial infarction, and arrhythmias. All these outcomes have some definitions we want to know about heart failure, stroke, infective endocarditis, and pulmonary hypertension. And for these outcomes, we defined predictors, potential predictors, which we think may have an impact on this long-term outcome. So we will examine the right ventricular outflow stenosis. We will extensively investigate the coronary anatomy just to study the impact on cardiovascular morbidity. We will investigate neo-aortic root dilatation and the progression of root dilatation and the progression of neo-aortic regurgitation, about left and right ventricular function, and also about diastolic dysfunction, because we think that in patients after the arterial switch operation, diastolic dysfunction may have an impact on the degree of aortic regurgitation. Also, we look for functional capacity, and we will collect pregnancies. The timetable is that we will include patients between 0 and 2 years. And with this cohort, we go on. So after 5 years, that means between 5 and 7 years, we have the follow-up of these investigations and we collect the outcomes. And this study has the potential to go on until 20 years, because we think that most of the outcomes, such as stroke, heart failure, and myocardial infarction, we will only see at least 10, 20 years after the study has started. And then after the first 2 years, we will hopefully writing some manuscripts on the anatomic and functional assessment of this young cohort, and we'll see if this anatomic and functional assessment has an impact on outcomes. We use as the database a digital database called Secotile. This is used in Switzerland, and this one is from Zurich, where you have a pseudonymized entry, so you do not know the patient's name. Of course, all this data are safe, as it should be by law. This is how it looks like. We did it very short. So this is for the ECRF for the cardiopulmonary exercise test. And as you see, we don't want to know all the numbers, because we are sure that we cannot use all these numbers, and we want to do the maximum which is necessary, but the minimum that we really need. So the current status is per March 2021. We have now consented 350 patients, included 257. The target should be about 700. And as you can see, we didn't have much luck at the beginning, because we started the study, or we wanted to start the study when the first wave of COVID-19 just went over Europe. So we couldn't include, we couldn't see patients, at least in Switzerland. We couldn't see patients if no emergency was. So that's why we had a delay of about 6 months, and now we will prolong the inclusion phase about 6 months. So the inclusion phase will go until July 22. These are all the centers, and also as you can see, Vienna is not here, but Vienna also has included patients, but consented patients, but we couldn't include because nobody was ever allowed to travel to Vienna due to COVID. So COVID is actually an issue for our study, because we do clinical study, and clinical studies in this time are difficult. But then when COVID-19 came, we had to rethink about our research and about our Epoch group. And what we did is we set up immediately a research task force about COVID-19. That's the Epoch COVID-19 project. So the Epoch network is actually a very good one. Then most of our members are also in the working group, board members in the working group of the ESC for adult congenital heart disease, also members in ISAC. And with this network, we could quickly establish a new network and collecting patients with COVID and congenital heart disease. And this is then the idea of this Epoch COVID-19 life tracker. And you can see our first weekly report we had as soon as 6th of April in 2020. So finally, we had more than 25 European centers with Madrid, with Milano, centers from Belgium, so hotspots from the first wave. And we were asking to send us all definite patients with definite corona infection and tell us about their cardiac defect and about the clinical course and the clinical outcome. So we asked for the cardiac defect, we asked for cardiac defect complexity, gender, age, BMI, comorbidities such as hypertension, diabetes, etc., and related problems. So within weeks, it gave us an overview about what's going on with our patients in Europe. And relatively soon, we could guess that complexity, for instance, was not an issue, but it was comorbidity, it was BMI, etc. So we did then a survey among European experts, because at the beginning of the COVID wave, everything was based on expert opinions in congenital heart disease. I had a friend from China, and I was asking him if he knows something about patients with congenital heart disease, because China was even before Europe, and I didn't get an answer. So this group of patients, they were completely out of the scope. And this survey, we did it in March 2020, and you see here, we just asked if you think that ACHD specific risk factors is a risk or not. So pulmonary and it was clearly that the group, all these 28, I think, or 30 experts, they thought that pulmonary hypertension, cyanosis, and Fontan circulations, that these patients are at highest risk for having a severe course of COVID-19 infection. And other like a mechanical valve, even in the beginning, people were thinking, no, that's not an issue. And we know now that particularly pulmonary hypertension cyanosis is an issue, but less Fontan circulation, less reduced ejection fraction, and less valvular dysfunction. Also, we were asking about general risk factors, and even in March 2020, the experts were quite right while saying sympathetic heart failure is a risk factor, immune suppression, and advanced age, but less male gender, coronary artery disease, and arterial hypertension. So the first wave we published in Heart with clinical outcomes of COVID-19 in patients with adult congenital heart disease. And you just have now learned about the international study from Greg Broberg and Jamil, that we have quite similar findings as they have. So in our groups, in the first wave, when we had the first 100 patients, patients with a complicated course, they were older, they had a higher BMI, and they had more comorbidity. And also what we saw is that complexity is not such important that we thought before. And particularly, we did not see that the Fontan circulation, the patient in the Fontan circulation had a worrisome course. We saw that pulmonary hypertension is an issue, but not valvular problems and not arrhythmias. So in multivariate analysis, we were showing that comorbidities, overweight, and cyanotic heart disease were predictors for worse outcomes. So this is the take-home figure about this study. You see that the highest risk have patients with cyanotic heart disease with BMI above 25, and the higher the BMI, the worse is the course. and also age and comorbidities are issues. So the outlook of Epoch. Actually, we now want to address again this study with the arterial switch operations and collecting the data and all the patients, but then we want to address other topics. And also, as I have told at the beginning, we are not an exclusive group. We actually want to we like to include more centers, and definitely we want to have more of these brainstorm meetings because we are very longing about these meetings. So I come to an end of my talk. I wanted to show you what Epoch is, and that Epoch is aiming to design and execute collaborative outcome studies in the field of adult congenital heart disease. That Epoch has the network to quickly and efficiently generate large numbers of cases to answer short-term outcomes questions such as new infections, new diseases, new problems we are faced to. I told you about Epoch ASO, this arterial switch operation cohort, which is a prospective international multi-center study aiming to provide a better understanding of adverse outcomes and their prediction in adults after the arterial switch. And the results of this study may help to optimize future care of this novel patients cohort in adult cardiology. I thank you very much, and now I'm open for your questions.
So thank you, Daniel, for a great talk and a great initiative. So if you have any questions, you can either just type them on the chat or just open your microphones and you can ask the questions directly. So Rachel is just congratulate you. That's an excellent talk and such an impressive network. So while people are thinking, so the first question, Daniel, if this, you said that it's not closed, you started with some centers. So how people can join if they want to join the project? How is just contacting you, or there is another way of joining, or how they can join? Because I'm sure there are a lot of people in the call that might want to join.
Mm-hmm. So I must say we just wanted to know if it works what we do. So that's the first thing. So we will now for the next months definitely focus on this arterial switch project. But then for further projects, I think you can write me, and when we plan another project, I will definitely come to you and listen to your suggestion, because up to now we have maybe 5 to 10 projects, but we have not decided on which project we want to go on. So if centers think that they really want to be part of this group, I think we are open. It's just that you have to keep in mind that the larger the group is, maybe the more problems you will have with these academic issues, you know. And this is something we want to overcome. We don't want to argue about authorship. So we want people to work, and everybody who is working and can do this work and can publish. But if you are 50 or 100 centers, that's not possible anymore. So I think there is something like the ideal size. I don't know if this is true, but yeah.
Dan? Oh, can I ask a question? Do you want me to put my hand up, Rafa, or how should we do it?
No, go.
Daniel, that was fantastic. I think you guys are awesome with everything you're doing. I'm so impressed. Could I ask you, how are you practically getting everybody to put in all their information about patients? I mean, do people have help in some way? I mean, you pointed out everybody is a busy clinician. So how is every center managing to get data inputted to you guys?
So, you know, all these centers, we have our registry. We have the Concord registry in Amsterdam, in Holland. We have the Spanish registry. We have the Swiss registry. So all these patients are already consented. And because we're doing study on clinical ground, we do not have to ask them again, because we just can use the clinical data. If we want to do something extra, let's say we want to do some troponin, etc., then we have to consent them. But otherwise, we have to write we have to write to our ethics committee that we do a sub-project, a nested cohort project of the registry. That makes things much easier.
So wait, are you getting consent from everybody then, but for the Swiss registry, or do you not even need consent at all?
In Switzerland, we have, when a patient comes to a university center, he has to sign a general consent, which says, can we use your clinical data? What you do anyway, so not something special, we can use it. Other centers, of course, they have to do the consent. And then we have now hired 3 or 4 fellows. So Switzerland has a fellow, Amsterdam has a fellow, Spain, I think, has 2 fellows, and they do the data entry. So first we thought that we have 1 fellow doing all the data entry, but this was not possible with COVID. So then they hired some fellows, or not hiring, I mean the fellows, they were anyway there. So these are university centers, most have some help or have some students for the data entry, and they do it.
Okay, I can't believe you get automatic consent. You are so lucky in Switzerland.
Yeah, we have, the only thing we have to be careful is with the imaging. So the core lab of CT is in France, and we have regular video conferences with this professor, I forgot the name, radiologist in France, who teaches us how we should do the CT, that we can measure all the same. Because when we measure the angle, we have to define how we measure the angle and how we have to do the acquisition. But it's not like we cannot do a core lab for every investigator. We cannot make a core lab for echo. We just have to rely, and this is definitely some of the weakness of such a research. It's not, yeah, but it's more outcomes. It's not about if it's 1 or 2 millimeter aortic root dilatation overall, but it's if we have root dilatation, does this have an outcome impact?
Well, I kind of agree with you. You can spend millions of dollars and have a core lab, or you can be practical, actually get it off the ground, manage to recruit people, not spend $1 million and get the study done. So at some point you have to be practical. A core lab adds a massive amount of extra bureaucracy and cost. But
yeah, we agree. So it's better if you have this SOP and at least you have the minimal standard of imaging. Then we all have, you know, not only that we measure in MRI left ventricular function, but we measure the same way. Yeah. Also, the acquisition is very similar. We have the same Teslas, whatever. Yeah.
I think that is a good example that we need to collaborate if we want to get numbers and we get outcomes. And we have to accept the limitations of a collaboration. But the thing, as you said, we are looking here is a clinical endpoint rather than if it's 2 millimeters or less or more angle might not make a huge difference in the clinical endpoint. So there are a couple of questions in the chat. There's a question here that is the ethical consent for ethical consent for 1 year or is lifelong for the patient? So when you consent the patient is forever or just 1 year?
It's, well, forever, as long as it's under my care. I can use the data. So I can use all the imaging data. I can use the clinical data that are performed or in clinic, not outside clinics. So I am not able to ask for another doctor to send me their numbers. So what I did, yes, I can use lifelong.
And who does consent the patient? Yourself, or do you have someone to consent the patient?
Myself. That's, you know, I mean, I see my patients in clinic. I know them very well. This is a question of 1 minute. I tell them, look, we are doing studies about congenital heart disease. We just use what you give us anyway. So it's nothing special. You don't have to come again and blah, 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 blah. So it's very easy. They know me. That's the good thing if you know patients. I think that's the strength of being a congenital heart doctor, that you see these patients over several years. They trust you.
Mm-hmm. So another talk here is thank you for your excellent lecture, and is not related to the research. It's just a clinical question. Do you use ARB or Vita blockers for patients with dilated aortic root in arterial switch?
No, I don't. If they don't have arterial hypertension, or if something else like arrhythmia is there, no, not because it's. I do not pretend them as patients with Marfan disease, for instance. That's the same in Toronto, isn't it? That's what I've learned.
Yes, it's the same in Toronto. Erwin?
Thank you, Daniel, for your fantastic talk. I'm very proud. Toronto is very proud of seeing many Toronto fellows on this, participating in this Epoch project. And that's a great effort, and I have to congratulate the European colleagues. And as I said, the bureaucratic barrier is huge. And actually in Europe, or at least in Switzerland, you found a way to tear down all these bureaucratic barriers with this consent, as you told us. I can tell you here in Canada that the bureaucratic barrier is huge. For instance, Bill Williams just wanted to follow all the master patients who are operated in Toronto, but some of these patients are living in Alberta or in BC, but he was not able to get the data about outcome data of these patients because of the RB is very reluctant or obstructive actually to that the centers in Alberta, BC can provide any data how these patients are doing, are they alive or dead, for instance. So this my question is, in Switzerland you have this simple way, and as I always say, the Swiss like it simple. The less bureaucracy, the better.
Well, it was not that simple as it sounds. So, but how it goes with ethics is.
I always say the bureaucrat not proactive.
If you do a national study, so with all the university center in Switzerland, if I am the main investigator in Basel, let's say, and I say this and this and this center is involved, then the ethical committee approaches the other centers. I don't have to do anything. That makes it much easier. So Toronto, for instance, or Ontario should go to Alberta and tell them, look, we are doing this study, everything is fine, accept it. And this is some agreement they have, and that makes it much easier.
That's my next question. Within the European Union, all the other countries are members of the European Union, but Switzerland is not. Is there a similar approach in the other countries in Europe, like in Germany, France, or Spain?
Every center who is joining us has to have their own ethical agreements. This is no European rule, particularly not with Switzerland. I think Jack wants to ask something.
Well, I think that was just on that topic, because you were talking about how things work in Switzerland, but the projects that you presented were pan-European, several countries, and with a hope to expand farther within Europe. And I wanted some comments on what the problems were in getting the agreement and cooperation in other places besides the system that in Switzerland maybe made it somewhat smoother. I mean, how did they manage in Spain? How did they manage in France? They're quite different countries.
Well, actually, it was not harder than in Switzerland. So they also, I mean, maybe Pastora. I saw Pastora can comment, but so they had to get their consent, and we have it's a digital data entry. So I don't see any problems with these countries. And the only thing which we had to be aware is, for instance, the possibility to do a CT, a coronary CT. Is a country able, or is a center able to do a coronary CT every 5 years, or an MRI, and that it is paid? Because we don't have the financing that is paid. So I think that some countries cannot join because they are not able to repeat a coronary CT or an echo every 2 or every 5 years. So maybe there are questions of resources, or questions of resources also are that maybe a center has only one adult congenital doctor, and he's absolutely not able to do more than what he does. So this is a problem, and that's why we wanted to set up these fellow systems. That our first idea was that one of these Dutch fellows, they always have 5 or 6 or even more of these fellows, and that they will help out, and that actually is now also happening, that the fellow from the Netherlands, or this is actually the aim, that he will help out in Paris, and that our fellow goes to Spain, but it was not able due to COVID. And now we are lucky enough that Barcelona and Sevilla, they have their own fellows. But without these fellow systems, yes, it's impossible. So we need to build up a system of student and fellow, and otherwise we would work on weekends, and we don't do this anymore. But maybe Matthias is doing it. Yeah, Matthias is, but me not. But only on call.
Also, you make it not feasible if you don't have a system where you have somebody that is tracking the data and putting the data there. It's just as you get busy, and that's not going to be feasible. So I think that's a brilliant idea. So Netherlands did no trial like that. So the fellow were coming to every single center and sat in the computer for 5 days and got all your data. But I think that the future is having people that can do it in each center. I think that the idea is great. Do we have any other questions?
I only want to mention again that it's one thing is to have a multinational collaboration, but the other thing, and I think that's much more important, is that you still have fun with what you're doing. Because as being a researcher, sometimes it's quite frustrating that you have no money, nobody looks at you, at what you're doing, and at least we have then such events such as in South Bay with friendship and so on. And that's why I'm so convinced that after COVID, we definitely will have our personal meetings again, and not going on with all these online meetings. I don't know how you feel. I think things like this ACHD international rounds, that's perfect online. That's the way to go. But for personal meetings, we should meet, we should talk, we should see each other and drink something and eat and whatever. And that makes research stronger.
I fully agree with that. I mean, I think virtual meetings came to stay, but not to be the substitution of personal relationships. So I have one more question. So it seems that I have and you as well, the luxury of working on both sides of the pond. So working in Europe and working in North America. So I can see that we don't really join forces. So North America does, with our groups of things and the research here, and the Europeans do their own things, and which is any room for us to collaborate and having a much bigger vision, and of course joining forces and joining patients would be a much stronger outcome, and just stopping this American guidelines, European guidelines, and has a more joining approach to the disease.
Well, the first step what you should do is joining ISAC. Because ISAC is an organization that actually has the aim to have worldwide research, and that's the first step. And the second step is, of course, that we. And by the way, I have to say there is international collaboration. I mean, the COVID-19 from Greg, it's an international study. Although 75% were US centers, but about 20% were from Europe. And it's possible. It's just, we have to make it easier. The easier, the more we'll join. I think that's the point. If we have to do a lot of not only administration work, but also clinical work, with large database, nobody will join. Because that's so much time consuming, and at the end, you give your data for nothing. That's the issue. So we need outcomes, and I don't know how we make it with hundreds of centers, which would be the best, but that's very, very, very difficult. Because you have to know these guys you're working with. Do you have an idea how we should do it?
Well, I think it's difficult. I think that to be honest, in the congenital world is not that big. I think we know each other, you know, quite well across the centers, both sides of the ponds. I think that the idea is just to get us to work together. The problem is the problem you said, and the more people you have, the more fighting you're gonna have academically, and that could be an issue. But I think that's doable, and having rules and having personal projects and allowing people to have their own projects within the group increases significantly the happiness of the group and the possibility of people joining. So I think that, you know, it's a great idea to have a European or collaboration for research. It's another one here in North America. So I think that at some point the collaboration between the two, the North American and the European, is absolutely possible, and many of us are members of the North American group. So I think that I can see that happening in the future, having just clear instructions, clear rules from the beginning. If you make clear who is going to do what and who is going to be the author or the first author or the last author of each thing that happens, I think that the collaboration is is just to support the research. But after, in this case, you have a project that is European wide and come from probably that brainstorming. But you know, if in 5 years somebody might come from, I don't know, from Austria and said, well, look, we want to do this project, we want the support of the Epoch, you know, but it's going to come from Austria, and the PI is going to be in Austria, and you guys going to collaborate. That's how I see that might happen. And you know, we might, let's say we do collaborate and say, well, Toronto wants to do this project, do it through Epoch, but Toronto is going to, or North America in Toronto, the center is going to be the PI. And I think that if you made that clear from the beginning, people know exactly what they are joining. I'm sure that is it's possible and will be an advantage for us to get more outcomes, because I think the only way of moving forward the congenital heart disease world is us collaborating and putting our numbers together, because all of us have a few of this and few of that, and some centers are luckier to have more number of patients, but even large centers as ours, we cannot just alone get the outcomes that are needed for this population. So, and I think that centers like ours, we have larger number of patients are gonna, you know, benefit a lot from joining collaborations like this one for the benefit of the patients, because actually, as you said, you do this for the benefit of the patients and for having fun with friends, which is absolutely important. If you don't have fun with friends, then this is not going to work.
I agree.
Okay, so it's 9:05. So Daniel, it's been a great pleasure. So great talk, and nice seeing you. So
very nice.
Haven't seen you for a while.
Really nice. Yeah. Thank you for joining.
Thank you for joining us. Thank you for this amazing initiative, and thank you everyone for joining us today. And see you here next week. And good morning, good afternoon, or good evening, wherever you are in the world. Bye, Daniel.
Bye-bye.
Have a nice weekend. Bye-bye.
Bye, Daniel.
Bye.